Welcome to Policy Brief, an informed and engaging conversation with policymakers, policy influencers, and public sector professionals. This is brought to you by the John Glenn College of Public Affairs. My name is Trevor Brown. I'm proud to serve as dean there. And I'm joined today by Wayne Turnage, all the way from the District of Columbia, where he serves as Deputy Mayor for the District of Columbia Health and Human Services and Director of the District of Columbia's Department of Healthcare Finance. Welcome, Wayne. How you doing?
I'm doing fine. Thanks for having me.
Oh, it's my pleasure. What hat are you wearing today? You got lots of hats. Are we Deputy Mayor or Director?
It depends on what minute of the day you catch me. I move thanks to a very capable staff that surrounds me. I move in and out of both roles by the minute, actually.
So before we jump in here to the meat of this, I want to do a little of the Civics 101 here. So you are a deputy mayor, which, mayoral positions we often think of as elected. So I assume this is an appointed position, but then a director we think of as sometimes as more of a civil service position. Just educate us a little bit. Are these both appointed positions, or are there some distinction between the two?
Yes, they both are appointed positions. The deputy mayor serves in the cabinet in the executive office of the mayor, along with 4 or 5 other deputy mayors that basically cover the functional areas of government. It is an appointed position, but also the agency directors are also considered to be in the mayor's cabinet and subject to her appointment. And so both positions are appointed. One is actually in the executive office of the mayor. The other one is in the broader cabinet.
So did you draw the short straw, or was this is this a typical pattern to marry these two positions together?
I don't think it's typical. I was initially working as a director of the Department of Healthcare Finance, and I have been doing that since 2011 when I came to Washington, D.C. to work for a former mayor, Mayor Gregg. Once Mayor Bowser was elected, she asked me to stay on as the director of the Department of Healthcare Finance. And over time, she asked if I would consider the dual roles. I was very honored that she would ask me. I was a little intimidated by the prospect, but feeling honored that she would ask me and always looking to help out wherever I can, I agreed to do both roles.
Well, let me add my congratulations and condolences. Never one of these jobs, it's got to be 3 times as hard to do too. So let's dive into the roles. Tell us a little bit about the primary responsibilities. And here we're setting up what was your office focused on before COVID hit, sort of January, February 2020, and who are the primary client populations and how do you serve them? Okay,
well, let me start with the deputy mayor's role. That has a sort of a higher gaze from where I sit. The general mission of the deputy mayor's office of Health and Human Services is to really coordinate a really comprehensive set of benefits and services for district residents who sort of live on the economic margin and those who have some significant disabilities. We cover both children, individual adults, and families with the desire to sort of step in the gap that exists in their lives to make sure that we can help them move beyond some of the challenges that they may have or live better with the challenges that they have. So in that context, there is a cluster of agencies that includes the agency we just talked about, the Department of Healthcare Finance, primarily funds healthcare for persons who are low income. We cover 40% of the district's residents. There's the Department of Health, which is, as the Department of Health do across the country, they focus on providing population health care and also providing a full range of public health protection services to the residents of the district. We have our Department of Human Services, which is responsible for the execution of all of the safety net programs. They cover food security, cash assistance, and we provide an extensive set of services to persons who are experiencing homelessness. We also have an agency called the Disability Services Agency, they probably serve the most vulnerable population in the city in terms of generally both income, but also they have some profound disabilities that are both physical and intellectual. And this agency does a wonderful job of providing access to healthcare services and the supports that this population needs to live as comfortably as is possible, given some of the challenges that they face. We also have the Department of Behavioral Health, which is responsible for all of the mental health services that we deliver in the city, both in the community where they fund services and in institutions where they are the operator of the state hospital. And finally, we have an agency on aging, and they basically have a range of services that they provide to our seniors with the goal of helping our seniors improve their life and helping them age friendly, as we call it.
So you used the phrase a few minutes ago that primarily you're serving vulnerable populations in the District of Columbia. Pre-COVID, what were the primary challenges that these vulnerable populations were facing? What were the things you were most concerned about trying to address for, and you could pick one or sort of describe a broad set of challenges?
I think the biggest, probably one of the biggest challenges pre-COVID was the challenge of helping our vulnerable population negotiate, a very complex healthcare system. Under the best of circumstances, our healthcare system is pretty complicated. And if you don't have the necessary supports and resources and information, it can be a very daunting challenge to try to negotiate. Now, the district has the benefit of being, I think, the second, of ranking second in the country in terms of having the highest insured rate. So the problem has not been making sure people have health insurance, which is a problem in many other states. Our problem is making sure that people have real access to care once they have the health insurance. And that challenge falls disproportionately on the residents who live in 2 wards of the city, primarily wards 7 and 8, where they're low income. The healthcare assets in those areas are significantly less fulsome than what you would find across the city. And as a result, many of the residents find that they have to leave their wards to negotiate healthcare in other parts of the city. And as a result, some of them do not constructively engage with the healthcare system, instead using the emergency room as their primary care doc or waiting until they are really sick before they engage, which is really never a good thing. That is one of the probably the premier challenge that we had, and that cuts across all of the vulnerable populations that I mentioned. And we also are constantly working with our population on food security and cash assistance, because the way those programs are structured at the federal level, the more you earn, at some point you're going to reach a cliff in your benefits, and you're going to basically lose all of your food stamps and your cash assistance as well. So the district has, for years, worked to try to mitigate that cliff and they've done so on the cash assistance side in some ways. But on the food security side, we're still struggling with, and we were struggling with that problem before the pandemic, as to what we would do when people were making more money to disqualify them for food stamps, but not enough money given the cost of living in DC to live independently of the need for that program. So those are probably 2 of the biggest challenges we face. And again, folded underneath the healthcare challenge are a range of difficulties that we have with the mental health system and making sure people gain access to and benefit from the range of services that we provide.
So it sounds like just an incredibly complex both set of challenges, but then the systems in place, trying to coordinate across levels of government and various sort of sectors, healthcare, human services, homeless services, et cetera. There's a lot of knitting together, I'm sure, of all of this. So let's pivot to COVID, and then we'll come back to how it impacted these challenges.
Okay.
Soon in DC and in your office, did you realize that COVID was going to have an impact on the clients that you serve? And what were some of the initial indicators that you knew that this was going to be a problem.
Yeah, you know, it's very interesting. When the news began to surface nationally that in January, late January, February, that the country was starting to see a small but worrisome number of persons who were infected with this thing that nobody really understood, at least from at a layperson's level. We had not been, at least there had been no reported cases in DC really through mid to late February, and we didn't really see any around the first couple of days of March. Now, but we were fully aware when we're looking at the national news and looking at what other states were experiencing that it was coming. And so we were working with our health department, it's called DC Health, and the director of our health department, who is just fabulous at what she does, and trying to get our arms and hands around what this virus would mean for the district. And it was in that process that we got our first confirmed case. I think it was March 7th. And then that sort of triggered a series of actions that were instrumental in helping us sort of stay out in front of the virus as much as one possibly could. But because of our discussions with the health department and because of the mayor's proactive status on this, she basically established a mayor's order, and I think it was the last week in February, that said, I'm going to build a consequence management team, much the way we do with other emergencies, that changes the reporting relationships in government, that elevates people who are on the ground to have direct access with the mayor, and she surrounds herself with a team of experts in different functional areas of government, and we work to manage this process with her. And then shortly thereafter, she basically triggered the opening of the Emergency Operations Center, which is also used, it's activated when we have citywide emergencies. But then we got the first case, and things got started moving pretty quickly. When we got the first case in March 7th, then the second week in March, the mayor established $1 million cash reserve fund. She said basically we need some dollars to be ready. And then from March 11th to the end of March, a number of activities were taken as our cases began, the number of reported cases began to increase. You know, she declared a public health emergency. There were limits placed on the number of people who could gather in a group. And then she triggered a citywide response plan that effectively closed out large convention center for business. She further restricted size gatherings, all in the hope of reducing the likelihood that we would have the kind of experience that New York was at this point struggling with. You know, in a very difficult decision, we had to put distance learning in place in the schools, which is a challenge in the city because the schools are more than just an educational resource for some of the kids because of the district's poverty rate. You know, kids rely on the schools for a lot of things, including meals. And so that was a difficult decision for the mayor to make. And then when it was clear that the virus was exploding in New York with these macabre-like implications and the devastation that we were seeing, and our numbers continued to creep up, the mayor decided to close, you know, all restaurants and bars. She shut down all recreation sites, nightclubs, spas, fitness clubs, and emphasized the need for social distancing and wearing masks when you were not able to social distance. And then this culminated at the end of March with her deciding to issue a stay-at-home order. And, you know, those were the sort of broad things that were done. And even at this time, it was not clear to me what this would mean for for the populations that we are responsible for. It was only when when we saw the reports about the rapid spread of COVID out west amongst congregate populations that we really became concerned that we would have to make some adjustments to how we were sheltering people or providing care for people who were in congregate settings. And that triggered a whole nother set of activities.
When you used an important word there that I want you to just explain, you said congregant settings. What do you define that a little bit and explain, and then start to talk more about, Ward 8, Ward 9, what did this mean for those populations?
Well, congregate settings are places where people live in significant numbers. Sometimes in a dormitory style setting, like we have in our shelters, but other times you have, maybe 2 people in a room in a nursing home or a assisted living facility. And we begin to see reports, and really some of the reports that came out of, I think it was Washington State, where significant numbers of residents in one nursing home died. And it was a rapid sort of, the virus went through the facility and at a rapid pace and killed people rather quickly. And it alarmed not only folks in DC, but everybody across the country. So we had to basically take a look with the assistance of the health department and CDC guidance, how we needed to change the way we were, either delivering services in congregate settings like shelters, or paying for services in areas like nursing homes and assisted living facilities, and even in hospitals. So that was probably the biggest initial adjustment that we had to make.
Let's focus on one of these. Take homeless shelters. Explain that a little bit more. Tell us about the dynamics of how a homeless shelter would work in normal times, and then how COVID impacted your ability to deliver services, and then how you responded. Just focusing on these shelters.
Absolutely. In the district, we have what we call low barrier shelters, where anyone who is experiencing homelessness can present themselves for shelter, and they can, stay the night. Typically, the shelter is closed during the day, and requires the residents to go out and work or seek other services that they may need. And so the typical, we have in our low barrier shelters, we have shelters for women, we have shelters for men, we have shelters that serve both men and women. And what we do not have no longer in the district, the mayor closed all of the family shelters. We did not, the mayor was strong or adamant in her belief that, shelters, regardless of how well run, were no place for children. So we have this sort of dichotomy of a family, short-term family housing for families, and we have low barrier shelters for persons who are experiencing homelessness. And then outside of that system, many folks who are experiencing homelessness refuse to move into shelters, and they set up what we call encampments on the streets. And so the process for working with residents who were living in encampments had to change as well. Typically what happens with encampments, because the district has a law that you cannot permanently establish tents or other abodes on public property. So at the same time, we have a right to shelter law in the district, and we try to encourage people who are living in encampments to move to shelters. But if they don't, then we have to make sure that there are no public or health hazards surrounding these encampments. And to do that, we conduct regular cleanups where we basically give them notice that we're coming. We give them a 14-day notice that we're coming to clean up the area that they should not be living in. And that cleanup, if they leave anything when we arrive on the 14th day, if they leave anything that they decide to leave, then we will either dispose of it depending on its condition, or if it's we believe it has some value, then we will store it. But the whole idea is to clean the area thoroughly. If we see an immediate hazard, we can establish what we call an immediate disposition, and we come back and we basically once we say that this is an immediate hazard, we don't have to give a further notice. We come in and do a thorough cleaning. But once we had problems with COVID, CDC came out with some guidelines that basically were designed to restrict the need for persons who were living in encampments to leave the encampment and move about in the city, because you didn't want to expose them more than they already were exposed to the possibility of contracting the virus. So we had to basically, and also we had to be cognizant of the fact that they did not have access to some of the basic things you would need to slow the virus. They didn't have hand washing stations. You know, in many cases there were no porta johns. So we basically changed our policies. We stopped doing, for the most part, full cleanups, and we would go out and just pick up around the area. We provided trash bags. We provided hand washing stations, all in the effort to, and we encouraged, you know, regular hygiene. And we continue to push with where we have these assessment teams. We continue to try to push to encourage these members to move to shelters. The problem was, in the shelters, we had to depopulate the shelters. Because we had shelters set up in a way that you couldn't honor social distancing, we had to basically eliminate some of the beds in the shelter and reduce the number of people who could therefore stay there. In the process of doing that, we set up temporary shelter for people who were vulnerable to COVID based on risk factors, or people who were exposed to COVID or who were known to or were determined to be positive. We put them up in hotels until they would could either clear the virus from the standpoint of being in quarantine, or if they were if they have a significant risk, then we would leave them there until the goal is to try to leave them there until the pandemic gets somehow arrested.
So none of these steps sound inexpensive, and you are in charge of healthcare finance. So you are both responsible for, on the one hand, in your deputy mayor role, the programmatic focus, but on your other role, you got to figure out how to pay for all this.
Yes.
And budgeting is an exercise in prioritization. And I can't imagine that as a city, you were able to do everything that you would hope to do for these client populations. Talk a little bit here as we come towards the end of this conversation about how you prioritize the populations. Did you try to serve all of them equally, the ones that you mentioned at the beginning? And similarly, how did you decide how to prioritize which services to get them, given what I can't imagine were easy circumstances on the programmatic side and on the financing side?
Yeah, well, the first thing we did was, because you're right, the budget pressures are enormous. I mean, they're absolutely enormous. And we were very fortunate, like many states, that the federal government has began to, or did begin early on to outline how we could apply for some relief. So we moved forward rather aggressively on several levels. First, we decided to do a sort of a full scan of the entire low-risk population that relied on us for healthcare. And we radically changed the rules that they could use to access care and to recertify for care. Basically, we, working with our federal partner, we made it possible for people to establish eligibility and maintain eligibility without meeting the extensive document requirements. That put them in the healthcare system, and it ensured they would have coverage should they need to go to the doctor for any reasons, but certainly because of COVID. Then we targeted the persons who were at risk for a significantly adverse outcome if they were to get infected. And this was primarily the minority community in wards 7 and 8. And we have a heavy Latinx population. I think it's in Ward 4. And we began to see what we saw nationally. We saw infection rates and death rates that were extremely disproportionate to their representation in the population of the city. And so we, through a contract, we worked with a vendor to get out targeted messages to this population about how they could protect themselves as best they could, as best as possible. And we encouraged them to pursue all of the methods that would be necessary to sort of hopefully ward off this virus. The other thing we did was to use a lot of the city's resources and federal resources to supply our providers who were providing care to people who were in congregate settings or who were living at home with disabilities with as much public with as much PPE as we could fund. One of the biggest challenges, particularly in home care, a lot of the home care agencies did not have the resources to staff their workers with the appropriate protective equipment. And so we use city dollars to make sure that this population, the nursing homes, home care providers, had the necessary PPE to allow them to go into the homes of those who need it or provide care to those in the institutions to ensure that they were properly protected. It was not as smooth as I just described, because there were always complaints and pushbacks from various providers and that they didn't have enough PPE. So we were constantly working with vendors who were providing PPE, building a PPE supply, and then trying to find ways to distribute it through the mayor's incident management team that was put in place. So it was, that's kind of where we focused a lot of our efforts.
It sounds just like an amazing set of steps that you all had to take and deal with this crisis, which sadly is going to be around for a while. Talk now as we conclude, what do you see as the lasting impacts of COVID, and perhaps reflect a little bit on, has it helped people understand the fragility of the healthcare system and the challenges that many of these vulnerable populations face? And hence, are you hopeful about changes we might make to the healthcare delivery system in the future? Or is this still, we're in the thick of the crisis and can't quite yet see the what comes next phase? Forgive a complicated question, but curious to hear what you think about the future.
I'm very hopeful about the future. I think we have in the district, one of the, I hate to call it a benefit of COVID, but clearly one of the things that the district had stalled on was what to do about the healthcare challenges of the people in wards 7 and 8. And how do we deal with a situation where a city as awash in riches as Washington, D.C. could continue to stomach a circumstance where the sickest residents in the city had no real access to anything but primary care, and that was on a very limited basis. How could we justify continuing to operate a healthcare system that had a hospital that was in an underserved area that was not viewed as being able to meet the needs of the residents of those two wards? How could you continue to have a situation in those two wards where there was absolutely no specialty care? And how do you particularly accept that when you look at the mortality, the morbidity, and now the mortality rates for their population, and they're 2 and 3 and 4 times, depending on the disease you look at, they're 2 and 3 and 4 times higher than what we see across the city. And I think the mayor put together a very comprehensive and expensive and challenging set of proposals for the council to build a new hospital in Ward 8, to add 2 urgent care centers in Ward 8, to build a outpatient clinic in Ward 8, an ambulatory clinic tied to the hospital in Ward 8. And then also to use our tax abatement powers to provide Howard University, which trains more minority doctors than any medical school in the country, and serves as a key provider of some of our at-risk population. How can we help them remake their healthcare system, which has faced some structural challenges over the years? And we had swung and missed a couple of times with the council on that proposal, but this time it went through with a unanimous vote on both the first and second vote for building a new healthcare system in Wards 7 and 8. And I think there, in no small part, the presence of COVID and the knowledge that it was disproportionately sickening and killing minorities and Latinos in very, very high numbers was something that greatly influenced our legislators on the council. So I think that's decision, the proposal by the mayor and then the decision to approve it by the council will echo through history for those two wards. It will radically change how healthcare is delivered for the people in that ward who need it most. So that's the one benefit I see.
Well, that sounds like a truly profound benefit. So on that hopeful note, let's pull this to a close. Really, really appreciate you taking time out of your busy day to chat with us about the challenges DC is facing. And we're really thinking good thoughts and hoping that both you can survive the short-term challenges, but also really build the healthcare infrastructure to serve those vulnerable populations. So thank you, Wayne, for the good work you're doing, and thanks for spending time with us today.
It is my pleasure, and I really appreciate you having me. And my only parting request is see if you can put some pressure on the president so we can have some football this fall.
I'll do my best.